Hello, this is Dr. James again, and we're going to talk about Chapter 21, Management of Labor and Birth of the At-Risk Client. This is where we're going to get into more detail and those types of things. Dysfunctional labor is what we'll spend a lot of times on, and the reason we need to assist labor. So we'll talk more in depth about that, even though we talked a little bit already. These are just some things you can look at on your own. Dysfunctional labor. It's a big word. Sometimes we call it dystocia, but it's one that does not result in a normal progression of what we're looking for in labor: cervical assessment, dilation, and the actual fetal descent. There's trouble with the five P's if you can't remember anything else. There's problem with the powers, the passenger, the passage, the psyche, or something with all of them. The risk factors, many times it's epidural, or we're giving her too much analgesia. Um, she may have more than one baby. It could be twins, trips. It could be hydramnios. It could be oligohydramnios. It could be polyhydramnios. She's just exhausted and the labor is no longer effective. She is not pushing effectively enough, and so her labor is not progressing enough to cause cervical dilation. Or the occiput posterior position is the most difficult position of the baby to deliver appropriately. So that's a cause for dystocia. Another risk, she's got a long first stage of labor. She's a short person and she's never had a baby before. The birth weight is over 8.8 pounds. The shoulder may be causing the dystocia. Shoulder could be down into the vaginal canal instead of the head. There could be an abnormal fetal presentation or positioning, or there could be some anomaly that is causing the baby not to get into the birth canal the way it should. It could be a reason for dwarfism, hydrocephalic, where the head is just way too big or the body is too big. She could be over the age of 35. High caffeine intake can cause us to have a dysfunctional labor. Overweight, a gestational age of over 41 weeks. So this is why it's very important for us to determine what gestational age she is. Could be a choreo, ineffective contractions, or the baby could still be very high even though the cervix has completely dilated. This is a picture of a shoulder dystocia with the healthcare providers and nurse using McRoberts maneuver to get the shoulder dislodged so the baby can go ahead and be delivered. The reason we're having to use this measure to get the baby dislodged is because you see where the chest is. It's being squeezed. This is going to cause the fetus to decompensate quickly. So, read in your book about the McRoberts maneuver. You may have even seen this occur during a vaginal birth in the labor room. Causes with problems with the power. Hypertonic uterine dysfunction. That means the uterus is contracting too much to be effective, or hypotonic is not contracting enough. There could be a protraction somewhere, or labor could have arrested, just stopped, or labor could have happened too quickly and the baby has not engaged or moved. There could be problems with the passageway. And another thing that I will talk about, precipitate labor, is happens so quickly that the baby has not rotated the way it should, so it has gotten hung or a shoulder has gotten hung. Problems with the passage, there could be some type of contraction with the pelvis, or there could be some type of an obstruction, like some of you have seen some fibroids, really, really large. There could be problems with the passenger, like I said, the OPP, occiput posterior position, or a breech presentation. There could be more than one fetus. The first one delivered fine, but there's a dystocia with a second one. There could be a macrosomia or cephalopelvic disproportion, a structural abnormalities. You can see these with table 21.1 in your book. She could have so much psychological distress or stress that we're having problems with her cooperating with the labor, causing her labor to be dysfunctional. So, can psychological stress contribute to the dystocia? Yes, it can. So, what is our assessment? We've got to have a good history of the risk factors. What is her frame of mind? Get our baseline vital signs. Put a monitor on, see what her contractions are doing, and find out what the fetal heart rate is. Do some Leopold maneuvers to determine what's the fetal presentation, what's the position. Our nursing management from table 21.1, we want to try to promote the progress of labor, provide physical and emotional comfort as best we can, and promote empowerment, get mother back in control. Preterm labor is a problem. We want this baby to not be preterm. And preterm is defined as regular uterine contractions where she's dilating and effacing. And this happens at age of viability till 37 weeks gestation, from 20 to the completion of 37. It's one of the most common obstetric complications, and so we want to predict if she's at risk for preterm labor. There are no clear first line drugs to manage preterm, but some of these may help to manage the contractions and could sometimes prolong the pregnancy for 2 to 7 days. And we give steroids for fetal lung maturity because we know the lungs are one of the last organs to mature, and the baby runs the risk of having respiratory distress syndrome. So we give steroids for lung maturity. She may even be placed on antibiotic prophylaxis, especially if we find that she is a carrier of group beta strep. Sometimes group beta strep can cause her to go into preterm labor. So the risk factors for preterm are in table in the box 21.2 in your book. You can look at those and have a good knowledge of those. Know what the subtle signs are. Sometimes she'll just start having some contractions. Sometimes some just things that she just bypasses, leaky membranes. Um, the contraction pattern for us to think that she may be in preterm labor, 4 contractions every 20 minutes, or if she has experienced 8 contractions in an hour. We'll want to do a CBC or urinalysis. We need to do an amniotic fluid analysis. A fetal fibronectin. The important thing about the fetal fibronectin is we need to know if she has had sex within the last 24 hours because it will not be accurate. She may be early in her pregnancy, and we need to do a cervical length by transvaginal ultrasound. We can do a salivary estriol level, or we may have to have her doing home uterine activity monitoring. But many times, and most times in my experience, if she's threatening preterm labor, we're going to have her in the labor room monitoring her uterine activity. So, signs and symptoms: contractions that could or could not be painful. She may feel like she's having cramps. She might feel like the baby is balling up. pain, discomfort, or pressure in the vulva area or even in her thighs, a change or increase in vaginal discharge, pelvic pressure and feels like the baby is pushing down, abdominal cramps, sometimes she can have diarrhea along with it, or just a sense of, I just don't feel good. Um, those are signs and symptoms. And you can see these signs and symptoms could be of, aside from things happening with the baby, some of these could be signs and symptoms of other. Our goal is to stop preterm labor before she's at 3 centimeters. Identify and treat the infection, especially if she has a urinary tract infection. Believe it or not, a UTI untreated can cause mom to go into preterm labor. Um, and tocolytic drugs is what I'm looking at. It is not on page 700. Let me see if we still have a good listing in our book for you, because these tocolytic drugs are very important, especially whenever she's running the risk of preterm labor. One of the tocolytics that are very common is called terbutaline, and it is one that we will use along with betamethasone. Okay, what I'm going to tell you to do is I'm going to look one more place because I really want you to know these. And I'm not seeing a good chart in your book that I have had on previous references that I have used. And I want you to have them. Okay. I don't think it's going to be in a table form like I wanted. Okay. Okay, the tocolytics actually are talked about on page 408 in your book, which is in chapter 20. But the ones that I really want you to know about are the beta adrenergics and um, the calcium channel blockers, because now we're finding that nifedipine, which is procardia, it's very good to use. But many docs are still going to want to use a frontliner as the beta mimetics like terbutaline or brethine and mag sulfate. But I'm seeing some of the younger GYN doctors preferring the procardia, the nifedipine. But please be aware, even though we can use these to slow down labor, sometimes they will also have side effects. So we have to be very careful with the tocolytics. And it can cause the baby to get tachycardic. So we can't use these for long term. We're going to treat the UTI with broad spectrum antibiotics. We're going to have her activity to be limited. She needs to be well hydrated, and we will use drugs, and we want to make sure that we're also using for the baby's respiratory. Beta adrenergics, just like I told you, terbutaline would be the one that you see the most often. Mag sulfate, prostaglandin synthesis inhibitors. Sometimes you will see them give Indocin, and calcium antagonist. And instead of page 741, these are on 408. And I do want you to know why these drugs might not be indicated. Um, And you would see the generic names, so make sure that you know what those are. So, lung maturity, we're gonna, for preterm labor, we're gonna give her some betamethasone or dexamethasone. These are given both IM, and we could usually give them safely between 24 to 34 weeks gestation to make sure we've got good fetal lung maturity. So, our job, tocolytics, educate, give her good psychological support. If we've got to keep her with us, sometimes I've, in my experience, sometimes we've kept them 3 months at a time. We let them decorate their room. We let them, as long as the water hasn't broken, and we can keep her safe and keep her quiet. We had one over Christmas one time. We had one over Cinco de Mayo. We let her put red hot chili pepper lights around her room, whatever it takes to keep her comfortable so that we can let that baby grow. Post term is when pregnancy continues past the end of the 42 weeks. We don't really know why. The risks are cesarean birth. Why? Because the baby has gotten larger. It could be a dystocia problem, a birth trauma. She could go into postpartum hemorrhage and infection because the baby has stayed in there so long. There is fetal risk for macrosomia, a shoulder dystocia, a brachial plexus injury, a low APGAR or post maturity syndrome, and even CPD or cephalopelvic disproportion. And as I've told you before, we as a nurse, when they come in and they tell us, they're so many weeks, we have to do some assessment to determine what is really the actual gestational age, especially if they come in and they have not had any prenatal. So this child is 17, she's pregnant, her menstrual dates are accurate, her date of conception is limited to one possible day. Her physician gives her estimated date of conception of March 28th, and she's gone past her due date. It's estimated date of confinement. That's the old term. She does not want to have her labor induced. She says, "My grandmother says the baby will come out when it's good and ready." Well, now it's April the 14th. She's 42 and 3/7 weeks gestation. And she calls the office and reports that she's having lower backache and she passed a big glob of bloody mucus. So, nursing assessment, we have to assess the estimated date of birth. Daily fetal movement counts. When was the last time your baby moved? They're going to have non-stress tests twice a week whenever they're post-assessment, an amniotic fluid analysis, weekly cervical exams. The client's going to have a good understanding of why we do this. Sometimes they're anxious because I know my date, and we're having to help them with their coping ability. Fetal surveillance is important. They may have to make a decision to have their labor induced, have a lot of support and education, and of course, we're going to have to deliver intrapartal care for them. What we know happens to that placenta after 40 weeks, the placenta is starting to get old, so it's starting to lose its efficiency. We're going to talk a little bit about an intrauterine fetal demise because we will talk a lot about it towards our last few weeks of lecture about fertility and loss. There's numerous causes for a baby to demise in utero, and it's very devastating for the family as well as those of us who are caring for them. What happens, they come in sometimes, "I haven't felt my baby move in the last 24," and we put on a monitor and we can't obtain fetal heart sounds. But the only way to confirm is by ultrasound, and we're not seeing any type of fetal activity. And unfortunately, if there's no activity, then we have to induce labor. And our job is to assist mom to get through this and get through the grieving process and make any appropriate referrals, especially to our good social workers, to help them get through this process. Umbilical cord prolapse is another one that can happen It's an obstetric emergency. You either have partial or total occlusion of the cord and a very rapid fetal deterioration. We've talked about this when I've talked to you about spontaneous rupture of the membranes. We want to prevent the risk factors if we can, and continuous assessment of the client and the fetus. As a nurse, we have to recognize this very quickly, and we have to do what we can to relieve compression off of the cord. And like I've told you, if you're doing a sterile vag exam and you feel a cord, we have to get the baby's head off the cord and keep our hand in place until we can get the mother to delivery. Sometimes the fetus is in high station, sometimes the fetus is very small, or breech, or transverse, or sometimes there's a polyhydramnios, and that cord is just floating all over the place. So, management, almost always we're going to have to run to the back in the OR and perform a cesarean. We need to relieve the pressure off of the cord. We can put her in knee chest position if we aren't feeling a cord, but we know it's cord compression, knee chest position, or a Trendelenburg. We can elevate her hips with pillows or a wedge and always put her on oxygen. This is some graphics to show you how we can put her in a knee chest to get pressure off the cord, or we can push the head up off the cord vaginally, or put some pillows under the hips to relieve the pressure. She's still going to have to go ahead and be delivered. These are just some things that we can help improve oxygenation while we're getting ready. We have her on the monitor, and then all of a sudden she has severe pain. She starts bleeding, and we can no longer see the baby's heart rate on the monitor any longer. So, we have seen abruption happen sometimes whenever she has decided she wants to do a vaginal birth after cesarean. So it's very dangerous. Uterine rupture is an obstetric emergency. It's marked onset fetal bradycardia. That's how we know that sometimes a rupture has happened. The risk factors oftentimes is previous C-sections or a vaginal birth after C-section. There is an onset of sudden fetal distress. Here again, sometimes we can feel the fetal extremities outside of the uterus. I don't like the way your book has separated it out because, anyway, whenever the uterus ruptures, she begins bleeding intensely. She starts hemorrhaging, and we can lose the mom as well as the baby in a uterine rupture. Your book talks about it on 345, and it talks about it again with us doing a trial of labor. Sorry, you probably hear a lawnmower running outside my window. Okay, page 345. I don't know why it's talking about uterine rupture there. Let's see. It is she will go into cardiogenic shock as well if she has a uterine rupture, and if not cardiogenic shock, and we don't get into DIC in this class, but that is strange. It is not on 345 except in this table where it talks about on page 345 a little snippet about uterine rupture, and it causes maternal hemorrhage, risk of death, and the fetus can become anoxic, the fetus can hemorrhage, the fetus can die, and neurologic sequela. So on the big table, 17-2, page 344, 345 is there. Um, we have to prepare for an urgent C-section. We cannot take mother off of the monitor. We're moving her down the hall into the OR and we're putting her right back on the monitor when we get there. Abdominal pain and tenderness. She's going to have chest pain between her scapula. She's going to go into hypovolemic shock. We won't see any fetal heart tones here. A cessation of uterine contractions, and we can actually feel extremities of the fetus outside the uterus. Really good picture here. See where you can see the uterus is actually torn open, so you can understand emergency. We have to stabilize the mother. We know we want to save this baby, but if we don't save mom, there will be no hope. It's emergency. We have to manage shock. We have to recognize that this woman is at risk for rupture. Some of these are multiparous, just like with abruption. Multiparous, she's more than one gestation. She's had previous C-sections. We have to be very careful if we're given an individual who's at risk for rupture oxytocin, because she can contract to the point that she could rupture. And we need to watch for signs and symptoms of hypovolemic shock. Amniotic fluid embolism is another obstetric emergency. You know, we're not supposed to have anything foreign in our lungs. Happens sometimes whenever there's some particulate matter in the amniotic fluid, and when we have a rupture, it gets into the lungs. There's a sudden onset of hypotension, hypoxia, coagulopathy due to breakage in the barrier between the maternal circulation and the amniotic fluid, similar to when a clot breaks off, but this is amniotic fluid and not a blood clot. She will have difficulty in breathing. Her blood pressure will drop. She'll turn blue, seizures, tachycardic. She'll have coagulation, failure. Just for the sake of this, and I'm not expecting you to know all about disseminated intravascular coagulopathy, DIC. This is where she is bleeding and coagulating all at the same time. She can bleed from every orifice of her body, and it can be very deteriorating. She will probably die from it. She'll experience pulmonary edema, uterine atony with subsequent hemorrhage, ARDS, and possibly and more than likely go into cardiac arrest. So we have to try to maintain oxygenation and hemodynamic functioning to correct all of this coagulopathy. And it's very critical, and it's critical care monitoring. Usually she'll feel really agitated or feel impending doom. She'll go into abrupt respiratory distress, heart failure, circulatory collapse. She will more than likely develop DIC. This is very fatal. And if she does survive, because of the lack of oxygenation to everywhere that it needs to go, she more than likely will have neurologic deficits. So back to Carol, she's not wanting to be induced. She's 42 and 3/7 weeks. We're discussing with her all the prolonged pregnancy issues, and what the risk she can have by prolonging. So what are the risks for the baby? And so we've got to explain to her what's required with a prolonged labor. Induction and augmentation, we've talked about this some, where we're stimulating contractions by medical or surgical means. With induction, augmenting, we're enhancing contractions after labor has begun. And this is if she's got a prolonged gestation, a prolonged premature rupture, a gestational hypertension, cardiac disease, renal disease, choreo, a dystocia, an intrauterine fetal demise, isoimmunization, and diabetes. So we're talking about induction and augmentation for complications now, just not just for normal pregnancy like we've talked about before. Cervical ripening, we talked about the Bishop score. Um, Herbal agents, castor oil, hot baths, and enemas, we don't really advocate for those. Sexual intercourse and breast stimulation, we don't really advocate for breast stimulation. What if her gestational age is off? That's what some people feel like they can do to get their labor to start. Um, we may need to use mechanical methods or surgical methods to induce her labor. Know what the pharmacological agents are. We talked about those, some misoprostol, and also oxytocin. But some of these issues that we've talked about, cardiac issues, other problems, we have to be very careful with labor inductions. For augmentation, we need to know what the gestational age is. What is the maternal status? What is the fetal status? What is the Bishop score if we're going to induce or augment? Look at the teaching guidelines on 21.2. Um, just, you already know about oxytocin administration and pain relief measures when we're inducing and augmenting labor. It'd be the same for these. We just have to take into account their medical conditions are. Oxytocin is important and it's used to ripen the cervix for labor. Yes or no? Oxytocin is inducing or augmenting once the cervix is ripe or once the cervix is favorable. What is an amnio infusion? If we're continuing to see variable decelerations because the cord is compressed, or if there's insufficient amniotic fluid and we think there's placental insufficiency, we'll do an amnio infusion. If there's post-maturity or rupture of the membranes, for preterm labor with premature rupture of membranes and to help deliver the baby, the provider feels like we need to have some more fluid inside. Or if there's thick meconium fluid and we want to do an amnio infusion to wash the meconium out to help decrease the chance for meconium aspiration. So it's important that we tell the mom what's going on, do a good maternal and fetal assessment, and prepare for cesarean if necessary. An amnio infusion is appropriate for a pregnant woman experiencing a prolonged second stage. Yes or no? No, it is for severe variable decels due to a cord compression, oligo due to placental insufficiency, just all the things that we just said. A forceps or vacuum assisted delivery would be indicated if she's having a prolonged second stage of labor. So here we are, vacuum assisted or forceps. We've talked about this previously, but now why are we using it? What complications are they important to use these for? Because we're putting traction on the fetal head. The reason we're using them is the second stage of labor may be longer than it needs to be. We're having non-reassuring fetal heart rates. The presenting part is not fully rotating and descending. There's limited sensation or inability to push effectively. The fetus is in jeopardy or in fetal distress. Mom has cardiac disease, or she has pulmonary edema, or she has intrapartum infection. She's fatigued, or there's some other infection. There is high risk for tissue trauma to the mother and the newborn, and prevention of having to use these things is the key. Prevention of any of these problems is key, but sometimes we do have to use them. And we have to realize that there could be a risk for a laceration, and so this puts mother at risk for hemorrhage. And that's just another picture of a forceps and some injury that could occur. You see the baby's face on C, some injury that could happen. Cesarean, you can see the figure on 21.8. We talked about classic and low transverse incision already. It is a major surgical procedure and it does go with risks. So, nursing assessment is important, getting a good history and physical, and she's going to get pre op and post op care just like she would in what you learned in med surg. She's delivering a baby, but pre op and post op care is the same. VBAC. We're talking about it from a complication standpoint. There's a lot of controversy because of the risk of a uterine rupture and a risk for the mother hemorrhaging. There are strong contraindications, especially if she has had a previous classic or if she has had several transverse incisions, because that's a weak spot in the uterus, and going through labor will make that area become even more weak. We have to get a special uh, consent from these that they do understand what's happening. They have been well educated about the VBAC, and we have to document really, really well. She's under constant surveillance, and we have to have the OR crew in place ready for an emergency C section at all times, especially if there is a rupture or she even has a risk for abrupting. The nurse is supposed to be the advocate for the client. We have to have strong expertise in fetal tracings and identify a non reassuring pattern as soon as it happens, because we have to be ready for a maternal delivery that's an emergent situation. The last terrible abruption that I saw for a VBAC, mother didn't even experience any pain. All of a sudden, we see everything going along good, and all of a sudden, no fetal tracing at all. We run her to the back. Her belly is full of blood. We deliver the baby. Um, Baby and mom were both saved, but had we not been there ready to go with the crew in place, it would have been opposite. The provider said it was the worst abruption he had ever seen, but we were trying to give mom her wishes and perform a VBAC. Okay, this ends all that you need to know from chapters 20 and 21. Of course, as always, you have any questions, please let me know.